Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to the final session of today's webinar series and the final days of the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit. As part of our final program, we brought you someone from China. Due to technical issues and social media matters between the United States and China and Facebook, she will be presenting today in a different capacity with an introduction as well as a final presentation. So our Chinese colleagues care for over 1.4 billion humans, and they have a very unique system of operating in the country. And Dr. Tang is going to give us a little bit more of a background about her presence at the university. And with that, I would like to make an important introduction. Dr. Chunbo Tang is now a professor, chief physician, and doctoral supervisor at the Department of Dental Implantology, affiliated Hospital of Stomology, Nanjing Medical University. It's a very famous university. She is now a standing committee member of Oral Implantology Subsociety of Chinese Stomatological Association, the chairman of the Oral Implantology Association, Jiangsu Stomatological Association, and a standing committee member of Oral Orthopedics Subsociety of Chinese Association of Plastics and Aesthetics. She's also an editorial board member of the Journal of Oral Biomedicine and Journal of Stomatology. She has been engaged in prosthetics for more than 20 years and has a thorough understanding of oral implantology. She once was a visiting scholar at the College of Dentistry, the University of California, for 1 year. She has hosted a total of 8 science projects, including the general product of National Science Foundation of China and other provincial and municipal projects. She has authored 1 book, over 60 peer-reviewed journals, including 18 SCI papers. She obtained a national invention patent, copyright of practical computer software, and 3 awards for Jiangsu Provincial Health Technology Introduction Award. She was one of the editors of the textbook of oral implantology for the undergraduate students. She won the titles of 6 Talent Peaks projects in Jiangsu province and High Leading Talents in Science and Technology in Nanjing City. We're very honored to have Dr. Tang with us, perhaps not live, but in her spirit. She's with us. I've really enjoyed having a conversation with her recently. And also back in 2018, when we did the Global Summit. She's very accomplished, and I highly recommend you guys tune in and listen to what she has to say. With that said, I will introduce Dr. Chunbo Tang via her introduction video.
Dr. Tang from Nanjing Medical University in Nanjing, China. I would like to welcome you to the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit. Due to the restriction on Facebook in China, I will not be able to present and be with you live. However, I have made a recorded presentation that we will play for you today. Thank you all for your listening.
Dear everyone, my name is Tang Chunbo. I'm from Department of Implantology, affiliated Stomatological Hospital of Nanjing Medical University in China. Today, I would like to share a very interesting topic. The topic is different designs for implant-supported fixed prosthesis in edentulous patient. As we all know, the whole world faces an aging population. In China, by 2020, according to the state media, people 60 years or older will make up roughly 90.3% of China's population. And when it comes to 2040, 50, the proportion will margin to 38.6%. And a bunch of problems followed this social phenomenon. For us dentists, the most considering problem is the aggravated trends of edentulism and expected edentulism. In an edentulism patient, rehabilitation has two main goals: to restore oral function and facial shape. Loss of the natural dentition involves resorption of the alveolar ridge. In other words, the change of occlusal vertical dimension, which could be transferred into denture space to designed prosthesis. According to denture space, we could classify residual alveolar ridge simply into three types. Class 1, limited bone resorption. Conventional implant-supported prosthesis will be good. Class 2, moderate to advanced bone resorption. When denture space over 12 mm, gingival porcelain and superstructure should be good. When extensive crown height space over 50 mm, hybrid prosthesis or implant over denture would be suitable. Last one, extremely atrophic vertical or horizontal bone resorption surgical procedure would be available. Radiograph should show the bone quality and quantity. According to the literature, the edentulous maxilla should be divided into three radiographic zones. The maxilla anterior teeth is designated as zone 1. The premolar region is considered to be zone 2, while the molar region is designated as zone 3. If we got bone, zone 1, 2, 3 have bone, and the posterior surgical plane is traditional implants. If zone 1, 2 got bone, posterior surgical plane need inclined implant, sinus lift or short implant in posterior, but traditional anterior implants. If bone only in the zone 1, posterior surgical plane is zygomatic implants or sinus lift, only grafting followed by implants. Insufficient bone in any zone, zygomatic implants or surgery procedure should need. Anterior bone insufficient, the posterior surgical plane should do the GBR, bone splitting, or only graft. There are many options to repair the edentulism. We could use 2-implant locator or 4-implant bar attachment supported overdenture, which is simple, minimally invasive, and cost-effective, but limited comfortable and function recovery. We could also use all-on-4 to repair the edentulism, which is also minimally invasive, fast, moderate price, and the function is relatively good compared to the overdenture. There are not what we are going to discuss today. Today, I would like to share some design for 4-arch implant-supported fixed prosthesis for edentulous patients, which is complex, expensive, but maximally restore the function. There are two main kinds of the 4-arch fixed implant-supported denture. One is cement retained, the other one is screw retained. For cement retained, first one, all single crown prosthesis, and the second is segmented prosthesis. Third one is one-piece prosthesis. And for the screw retained, there are two kinds of the prosthesis. First one, segmented prosthesis, and one-piece prosthesis. For one-piece implant-supported denture prosthesis, including two kinds of the prosthesis. One is on implant level, another one on multi-unit abutment level. For multi-unit abutment level prosthesis, one is ceramic fused on the framework, ceramic or resin fused on the framework. The other one is individual crown bonded on the framework. There are also a lot of the prosthetic material for different treatment structure. For cement retained prosthesis, we can use prosthesis material like base metal porcelain, or porcelain veneered zirconium, or others. And for screw retained, the material like casted-based metal ceramic, or hybrid like metal framework, acrylic, and denture teeth, and milled-based titanium resin, CAD/CAM PIC resin, CAD/CAM titanium bridge with individual crown, and CAD/CAM mononitrous zirconium. There are too many. Which one to choose? That is the question we want to discuss today. I think all of you here are very aware of these two ways of retention. And everyone here has their own tendencies. Briefly speaker, screw retention prosthesis has easy retrieval, extraoral repaired, and easy followed up visitors and maintenance, but it's difficult to require ideal implant placement or complete complex prosthesis. And while cement retained has better occlusal anatomy, but it is also difficulties like position of the crown margin remained cement, higher cost when individualized abutments are used, or intraoral repairs, limited retrieval options. When attend them to the 4-arch implant-supported denture, both of them requires complex procedures, requires experienced team with comprehensive understanding of the surgical restorative aspects, high expensive and high denture library with access to CAD/CAM. Experience, yes. More details difference will list. Briefly speaker, cement retained is easy for fabrication and passive fitting. It has lower cost and more freedom in implant placement. The crown of the cement-retented prosthesis have no screw hole, which could provide good aesthetic, but it is more difficult to repair, and cement remnant is several complications which can cause peri-implantitis, while screw retained is more expensive in fabrication but lower cost in maintenance. It has higher accuracy, higher technique sensitivity, and no cement remnant. It also has some potential complications like veneering, chipping, screw losing, and so on. According to the literature, in spite of proposed techniques such as vent-hole stand ports to improve the retrievability of the cement-retained restorations, screw retention becomes more necessary in extensive cases, which prostheses need more maintenance. So cantilevered prosthesis and full-arch implant reconstruction are best restored with screw retention. As we know, usually in maxilla, 6 to 10 implants for segmented prosthesis, 4 implants at least for one-piece restoration. In mandibular, 6 to 8 implants for segmented, 4 implants for one piece. One piece prosthesis is known for more freedom for implant distribution. Less implants, surgical cost reduced, splinted restorations allowed for cantilever, and also it looks aesthetic. But it also has limitations like high technique sensitivity, uneasy to get completely passive fit, welding point may be stress concentration area, also high cost for maintenance and repair. While segmented prosthesis easy for the fabrication and maintenance, oral hygiene, passive fit, and margin accuracy, lower technique sensitivity, allowing mandibular flexion, but it is also has limitation like high cost, more implants, and precise position of the implants, distal cantilever limited. We could see here the typical interproximal line, which is unavoidable for segmented prosthesis. For moderate bone absorptions or severe bone atrophy, it is difficult for cleaning and unable to meet aesthetic requirements, while one-piece prosthesis does not have this kind of problem. Considerate to the superiorities of the one-piece prosthesis, especially for its allowed for cantilever. It is perfect for the maintenance and adjustment for full-arch intermediate prosthesis. After we decided which retained structures should be used and whether segmented or one piece, we need to choose prosthesis material. we should master the characteristics of the different materials and related complications, difficulties, advantages, and recommendations. They will enumerated in the list. Long-term implant-supported fixed prosthesis success required maintenance, repair, and possible replacement within the patient's lifetime. As reported, less than 10% prosthetic success for implant-supported fixed prosthesis at 10 years. By 15 years, over 50% of the studies prosthetic demonstrated fractures or wear of the veneering material. Fracture or wear of the resin, chipping of the ceramic, fracture or losing of abutment and prosthesis screw were main complication. What we should bear in mind is that the complication will time-dependent nature of the phenomena. They should not be viewed as a limitation of this approach, but instead with a rational understanding that the prosthesis has a lifespan and that the patient can be best served by prosthesis designs that are age appropriation in regarding to hygiene, aesthetic, phonetics, function, and patient-based expectation, and with the knowledge that this expectation and their priority will change over the lifespan of the patient. In an edentulous patient, rehabilitation has two main goals: to restore oral function and facial shape. Loss of the natural dentition involved resorption of the residual region that entails, on the other hand, change in the maxillar-mandibular relationship, and on the other hand, change in facial musculature or morphology. Proper treatment planning involves lowering the progressive atrophy of the posture, that is, bone resorption, and the consequent loss of the soft tissue and hard tissue. Because the treatment is much more complex in situation in which it is necessary to replace both. Patient evaluation means analyzing several factors: bone availability, general state of the mucosa, hygiene, concision, economic cost, and specific prosthetic factors such as the immograous profile of the artificial teeth, degree of the residual resorption, facial support, and smile line. All these parameters influence selection of the appropriate treatment planning. In edentulous patient, the therapeutic possibility are basically overdenture, implant-supported fixed prosthesis, and hybrid. So, according to the study, 3 assessment critical to proper selection of the prosthetic design, like occlusal vertical dimension, aesthetic factors, or radiograph data. I'd like to show some cases with you guys. Case 1, cement retained implant-supported fixed prosthesis. This is a 45-year-old man. He had maxillar edentulous and mandibular partial edentulism, and he wanted to have a fixed prosthesis. A study model and interocclusal recorder was recorded. A diagnostic waxed denture was checked aesthetically and functionally intraorally. Then the wax denture was duplicated as the translucent denture and articulated on the articulator to verified into arch distance and the relationship. It could be made a radiograph template. CBCT examination revealed mild alveolar absorption of the mandibular and several absorption of the posterior maxillar alveolar ridges. Both based on the patient's requires fixed implant-supported prosthesis was selected for the construction of the forearch. So we made the surgical guide. According to surgical guide, 6 implants put in the mandibular and get the stability, and 6 the healing abutment put in the implant. We made impression with open tree. In some time, in 1 day, we finished the temporary bridge in mandibular. Radiological examination showed the significant bone value after right maxillar sinus flow elevator, and the perfect passive feature of the mandibular provisional implant-supported prosthesis. 6 months later, no obvious bone absorption around the implant, and then the prosthesis was removed. The initial implant level impression was made with closed tray technique. On the initial cast, a custom tray and plastic splint were made. After confirmed the position of the impression coping, reconnected the plastic splints. The definite impression was made using open tree technique with custom tree. In the next appointment, a face bone transfer and an interocclusal record were made and fixed provisional prosthesis. According to the implant distribution and anxious direction, 14 CAD/CAM fabricated abutments were designed. Some of the screw access holes were buckle inclined, so we decided to use the cement retained prosthesis. Resin framework were fabricated at the same time. Try in the resin framework and the CAD/CAM abutment. Check the lip support, spine line occlusion, clinical passive fit by direct visualization and radiographed. When nothing to be modified, albeit was registered for crucial record and send them all back to the laboratory. This is a final prosthesis, cemented retained zirconium prosthesis for maxillar, 1 piece cement retained zirconium prosthesis for mandibular. Radiograph examination showed the perfect passive fitting of the final prosthesis. Patient was satisfied with definitive restoration for aesthetic and function. So Although cement retention has a lot of the advantages, but the disadvantages should not be ignored. The advantages like aesthetic, better occlusal anatomy, easily passive fitting, or easily of the fabrication. Cement retained possesses disadvantages like cemented remnant abutment limited to at least 5 mm, high cost for repair and maintenance, and the limited retrieval option. Once again, cement retained structure does not shoot for all. We should structurally grasp indications and aware of its complication. Case 1 is hybrid prosthesis. A hybrid prosthesis is a metal-based prosthesis which replaces the missing soft and hard tissues with pink acrylic and missing teeth with acrylic teeth. This is a 70-year-old man. He had carcinoma of the mouth floor 8 years ago, and the surgery resection his mandibular block, reconstruction the defect with graft. He didn't go through the radio and chemotherapy, and he wanted to restore choosing function with fixed prosthesis. As we can see, the patient mandibular was partially edentulous in right inferior alveolar ridge. Luckily, the residual teeth in the mandibular was stable, and the case has available prosthetic space and appropriate interocclusal relationship. According to his clinical situation, and 4 implants supported hybrid prosthesis was selected. In the surgery, 4 implants was placed, and the wound was covered by idle-form gauze. The previous block resection provided extensive crown height space marked as yellow. 4 implant, 4 multi-unit abutment were inserted, and abutment level impression was made with open tree technique. Intraoral view, the artificial gingiva in reason, and the periphery prosthetic restoration were indicated to compensate for several absorption. Sufficient space was allowed around the implants to ensure the maintenance and sustainability of the restoration. Panoramic radiographs show the prosthesis has a perfect passive fit. So, features of the hybrid prosthesis: the atrophy bone absorption, extensive CHS over 15 mm. It has lower cost and comfortable, lower abrasion resistance, and frequent maintenance and easy stance. The third case I want to show you is posterior titanium implant bridge veneered with composite region. This is a 73-year-old man. He had the maxillar edentulism and the defect of the dentition along with several periodontal disease in the mandibular. He required for implant-supported rehabilitation and to improve improve the aesthetic and masticatory function. A study model and intercrucial record was recorded. Then a diagnostic wax denture was checking intraoral. Then the wax teeth was articulated on articulator to verify the inter-arch distance and the relationship. And some vertical defect was found in the posterior region of the maxilla. Prosthesis with artificial gingiva is indicated. A radiograph template was fabricated according to the wax denture. After valuable bone was evaluated and the prosthesis treatment plan was made, the location and the type of the fixtures were selected, and then the digital surgical guide was made. The surgical plan was placed 7 implants in the maxilla. The parallelism and the location of the implant were controlled and checked on the planning software. The digital surgery guide was not only served as surgical guide, but also used to fabricate the provisional implant-supported fixed denture prosthesis. So before operation, we made the temporary denture implant surgical guide, and we also choose the temporary abutment. The pre-surgical fabrication of the provisional restoration. The provisional framework was articulated on articulator to get proper occlusion, and the pink acrylic was used to restore the vertical defect. With the help of the surgical bite registration, proper seating of the surgical template was ensured. This is the intraoral view of the provisional prosthesis. We can see the perfect passive fit, and the aesthetic effect is very good. Post-operative panoramic demonstrated the position of the implants, the complete seating of the temporary titanium cylinders to the implants. 6 months later, X-ray showed ideal imaging of the osseointegration, and the prosthesis was removed. The definitive impression and the interocclusal record were made. A new provisional implant-supported fixed denture prosthesis with anatomic occlusal surface and adapted tissue texture was fabricated on the master cast, and then adjusted and polished intraorally. After 1 month's adaptation of the patient, send the new temporary complete denture to the laboratory as a reference model to fabricated titanium framework. The new provisional prosthesis shows the hidden transition line during and indicated ideal lip support. A milled titanium framework will send back the insert to the check for lip support, smile, and occlusal clinical passive fit. When nothing to be modified, the obite was registrated. 1-piece screw retained mental reason prosthesis was inserted. Clinical passive fit was observed from a occlusal view. We can see that all the screw access holes were positioned in proper place. The panoramic shows that prosthesis fit passively. After several months, patient came to complain for increasing mobility of the posterior teeth in the left mandibular and required for fixed prosthesis rehabilitation. After clinical evaluation, the number 37 needed to be extracted and wait for delay implantation. 3 months after extraction, CPCT shows significant bone value in mandibular. With the guide of the old removable denture, 5 implants were placed, and good primary implant stability were acquired. After surgery, impression were made immediately. In 1 day, provisional implant supported fixed denture were inserted in mandibular. 4 months later, after osseointegration were confirmed, definitive impression and intraoral occlusal record were obtained. One-piece screw-retained PEK framework was fabricated according to the provisional denture. One-piece PEK PMMA prosthesis were inserted. The panoramic showed the passive fit. 1 year later, veneer material in the left posterior mandibular fracture, so we removed the whole prosthesis and sent it back to the laboratory. 1 year later, resin fractures again at the same place, and the material show is better, although hidden. For above reason, considering the maxillar denture was matter reason superstructure, we chose titanium framework veneered composites as the superstructure for the mandibular. The features of the titanium framework veneer with composite resin is it is suitable for limited to moderate bone absorption. This material has slightly lower abrasion resistance than enamel, and perfect is aesthetic, but it is easy stance and resin fracture. Frequently maintenance is needed in the long time. Extract for the metal resin superstructure, we could also choose catechem zirconium screw retained framework and veneering porcelain. It is perfect, aesthetic and high intensity, but high technique sensitivity, and veneering porcelain chipping is very common. When extensive crown height space is over 50 millimeter. One-piece retrievable one-piece implant fixed prosthesis, which combined screw retention and cement retention, is a good solution. Here comes our fourth case: retrievable one-piece implant fixed denture prosthesis, complete months rehabilitation with one-piece screw retention, milled titanium framework, and cement crown. This patient, we can see the tilted and mill-aligned implants can be obtained through the correction of the multi-unit abutment, and we can after 6 months healing, 6 months of healing, the occlusal integration confirmed. We made the impression. In laboratory, the implant-supported fixed prosthesis were fabricated according to the provisional prosthesis. A rigid milled titanium framework was returned, which was attached to the abutment by a crucial screw. The vertical dimension, occlusion, aesthetic, phonetics fit of the prosthesis were checked intraorally. Once the prosthesis fit was verified, the abutment were screwed in and the crown were cemented to framework intraorally. Use the definitive cement. The bonding agent is located at the boundary of the gingival porcelain and the titanium framework. The final radiograph demonstrated complete seat of the all components. The patient's transition line is hidden during animating, alluring for nature and aesthetic clinical presentation to the patient. 2 years later, cement chipping of the first premolar and the right central incision were found. Remove the fracture crown without removing the whole structure. Take impression, send to the laboratory, then cement the new crown, which is very convenient. To decrease the chair side time and mark the screw access, ventral holes were used in the improved design. The crown will partly cemented to the framework in laboratory, which would decrease the chair side time, and the ventral hole crown was beneficial for the extrusion of the excess cement and indicated screw access. It is beneficial for later repair and maintenance. Milled titanium framework with the crown cemented on was retained. Once the prosthesis was verified, fit was assessed both clinically and radiologically. The rest crown were cemented to the framework. Ventral hole were filled by resin cement and was invisible. Retrievable one-piece screw retained implant-supported fixed dental prosthesis is suitable for moderate bone resorption and malaligned and tilt implant. The fracture of the screw retained titanium framework and cemented crown. Its retrievability, excellent aesthetic and high fracture resistance, better hygiene and stain resistance. Also, its great ability to customize and high cost. Another case is a one-piece screw retained prosthesis. This is a 50-year-old female complained her increasing mobility of the mandible teeth. And after periodontal treatment and economic consideration, we plan to keep the first premolar on both sides for removable puncture. Extract the remaining teeth and plan to give her one-piece screw retained prosthesis. 2 months later, after 2 months after extraction, 7 implants put in the mandibular. 4 months later, we did second stage surgery and extracted the first premolar. And also we made the master molar with face bone and interocclusal relationship was transferred on the simul adjustment articular. Consider the actual direction of the anterior 3 implants and the convenience of repair and maintenance, and the base of the base metal alloy with its higher modulus of the elasticity enable the framework to be designed with smaller dimensions and ensures the feasibility of this approach. We designed a modified one-piece screw retained prosthesis, which includes 3 milled abutment and matched extra formed gold coping with casting metal framework. After screwed the milled abutment into patient's mouth at the fixed, we placed the electro-formed gold coping onto the abutment, check position and fit of the abutment, and the electro-formed golden coping on the radiograph. Check the framework, verifying stability and passivity. Luckily, the structure is completely passively due to the framework onto the electro-formed gold coping with a composite luting agent and tighten the posterior screw. Interocclusal relationship was recorded by the OBIT. Definitive one-piece metal ceramic prosthesis was returned, inserting the abutment into patient's mouth and then playing the superstructure on the abutment, and check the passive fit with the panoramic radiograph. Everything is okay. For this kind of the prosthesis, the benefits is aesthetic and retrievability, and the shortcomings, the screw axis available, occlusal surface of the discontinuity. It's suitable male post implants, but the complication like uneasy for complete passive fit, gingival material fracture, veneer chipping, losing or fracture of the prosthesis screw, abutment screw, technique sensitive. The features of the metal ceramic prosthesis is limited bone resorption, ideally 7 mm, and it is aesthetic, minimally prosthetic well, and easy for maintenance and veneer chipping frequently. This is our last case. One-piece implant supported detachable technique retained fixed bridge. As we can see on with the help of the custom abutment, inclined or male-aligned implants can get common paths of the insertion easily. The framework with the gold coping is connected to the abutments by friction. No cement or screw is needed for the retention between the framework and abutments. Detachable technique retained fixed bridge is easy to fit passively, and the convenience for removed and then later maintenance. We can see the good aesthetic and panoramic radiograph show excellent passive fitted. Features of one-piece implant supported detachable telescope retained fixed bridge are that the bridge is retained by fraction, and it is good aesthetic. It is also has flexible decision and materials. Last but not the least, it is very convenient for removed and later maintenance. In conclusion, there are many different ways to restore the edentulous jaw, but we need to choose the right way according the different situation. This work cannot do without a good team, and this is my team. Thank you very much.